Hello everyone and welcome back. So we have started the preparation for gynae subject and we have discussed the first three topics, that is amenorrhea, menorrhagia and dysfunctional uterine bleeding. Now in the next section we are going to discuss the postmenopausal bleeding, the secondary dysmenorrhea and the menopause. We will try to cover all these topics from the gynae in 8 lectures and I will cover 3 topics in each lecture. So this is our second lecture for gynecology subject and the topic that we will discuss today is postmenopausal bleeding. Okay. So we are having a scenario that there is a 55 years old lady who came to OPD with postmenopausal bleeding. How will you manage? Then there is that there is 60-year-old lady with episodes of bleeding PV. So what is the DDs, the investigations, the management, and the causes? So the definition of postmenopausal bleeding is that vaginal bleeding after 1 year of the cessation of menstruation is called postmenopausal bleeding, and the causes are tumor of genital tract, inflammation or infection, drugs, and trauma. So the tumor of the genital tract is benign and malignant tumor of uterus, cervix, vagina, ovaries, vulva, and fallopian tube. Then inflammation or infection is vaginitis and endometriosis. Then drugs are HRT, anticoagulant therapy, intrauterine or postcoital bleeding, ring or pessary radiations, and decubitus ulcers. The others are blood bleeding disorder, there is a cirrhosis of the liver, and the bleeding from urinary or gastrointestinal tract. The differential diagnosis of postmenopausal bleeding is vaginitis, cervicitis, endometrial polyp or carcinoma, hormonal effect, and cervical carcinoma and ovarian tumor. The investigations that are done for postmenopausal bleeding are first of all, we will take the history, that is of bleeding, of vaginal discharge, of gynecological disease, of medical or surgical history, then the drug history, and then the family history. The examinations that are done for the postmenopausal bleeding are general physical examination, that is of prolapse, senile atrophy, and hormone replacement therapy, and the abdominal examination, that is genital tract malignancy, palpable abdominal pelvic mass, and ascites. Ascites present in case of chronic liver disease. Pelvic examination is done for severe changes and ulcer and growth and vaginal discharge. The dilatation and curettage is done for the diagnostic purposes, and hysteroscopic is done to visualize the endometrial cavity directly. Biopsy is done. Ultrasound is done, that is pelvic ultrasound and transvaginal ultrasound. Pelvic ultrasound for pelvic mass and transvaginal for endometrial thickness. Other investigations are complete blood examination and gram stage of the vaginal discharge, X-ray chest, liver function test, and coagulation profile. The treatment options for postmenopausal bleeding are causative, that is, treatment of the postmenopausal bleeding is cause directed, and the local estrogens are the cause, that is given for senile vaginitis. Metronidazole is given for trichomoniasis and candidiasis, and antifungal drugs are given for trichomoniasis and candidiasis. Surgery is done for tumors, chemotherapy is done for tumors, radiotherapy is done for tumors. Then the specialist is concerned for medical disorders. So we have discussed the topic, the postmenopausal bleeding, in which we have first discussed the scenario that there is a 55-year-old lady who came to OPD with postmenopausal bleeding. Then we have discussed the definition, that it is a vaginal bleeding after 1 year of cessation of the menstruation. Then we have the causes, which are tumors of the genital tract, inflammation or infections, drugs, trauma, and other. And the differential diagnosis are vaginitis, cervicitis, endometrial polyp, carcinoma, hormonal and cervical carcinoma, and ovarian tumor. The investigations options are history taking and examination, dilatation and curettage, hysteroscopy, biopsy, and ultrasound. And the other investigations are the following. The treatment options are causative and local estrogens, metronidazole, antifungal drugs, surgery, chemotherapy, radiotherapy, and then we will consult the specialist. Now the next topic is secondary dysmenorrhea. Okay, so we are having the topic secondary dysmenorrhea. First, we will discuss the scenario. In this scenario, there is a 35-year-old para 3 presents with secondary dysmenorrhea for the last 3 years, who gives differential diagnosis, management options, and the causes. So, what is the definition of secondary dysmenorrhea? Painful menstruation which is secondary to recognizable pelvic pathology, or dysmenorrhea which appears in patients who have experienced painless periods for some years during reproductive age. This is the definition of the secondary dysmenorrhea, that the dysmenorrhea is a painful menstruation which is secondary to recognizable pelvic pathology, or dysmenorrhea which appears in the patients who have experienced painless periods for some years during reproductive age. The causes of the secondary dysmenorrhea and the differential diagnosis. First of all, we have the congenital abnormalities and then the acquired conditions. The congenital abnormalities are rudimentary uterine horn, imperforate hymen, transverse vaginal septum. The required conditions are within the uterine cavity, that is endometrial polyp and intrauterine device. Then within the uterine walls are adenomyosis, uterine fibroids, cervical stenosis following surgery. Then the outside uterus we are having the endometriosis, the pelvic inflammatory disease, the pelvic adhesions and the pelvic congestions and ovarian tumors. The management options for secondary dysmenorrhea are hysterectomy, that is pain associated features, menorrhagia, dyspareunia, and urogenital abnormalities and vaginal discharge. Then the examination is done, which is general physical examination, pulse is BP, temperature, and weight. Pelvic examination, that is inspection of the vulva, the imperforate hymen, vaginal discharge, the polyp, and intrauterine contraceptive devices. Then we will do the ultrasound to diagnose the congenital abnormalities of the uterus, fibroids, tubo, ovarian masses, and PIDs. Then laparoscopy is done. It is the investigation of choice where no gross lesions are detected or when the nature of the lesions not clear, or ultrasound. Hysteroscopy is done for endometrial polyp and some mucous fibroids. Blood tests are done, that is full blood count, especially HB in patients with associated menstrual problems. Okay, now the treatment options for the secondary dysmenorrhea are causative treatment. Okay, causative treatment, that is the treatment is aimed at the eradication of the cause, and the medical treatment, which is danazol and antibiotics for the treatment of endometriosis and pelvic inflammatory disease. Then conservative surgery is done for removing the lesions only. Radial surgery is done in form of hysterectomy or adenomyosis or hysteroscopy. Then myometry is done, which is done in case of fibroids. And for congenital abnormalities, surgical correction in perforate hymen incised and rudimentary horn of the uterus is excised. For cervical dilatation, in case of cervical stenosis, polypectomy is done and polyp is removed. Intrauterine contraceptive device is removed. Progesterone and progesterone and dihydroergotamine is given in pelvic congestion syndrome, and psychotherapy is done. So we have discussed the topic, the secondary dysmenorrhea. We have discussed first the scenario for it, that there is a 35-year-old P3 present with secondary dysmenorrhea for the last 3 years. Now give the differential diagnosis and management in the options. So the definition of secondary dysmenorrhea is that it is a painful menstruation which is secondary to recognizable pelvic pathology, or dysmenorrhea which appears in patients who have experienced painless periods or some years during reproductive age. Now, the causes of secondary dysmenorrhea are congenital abnormalities, rudimentary uterine horn, imperforate hymen, and transverse vaginal septum. The required conditions are within the uterine cavity, which is endometrial polyp and intrauterine device. Within the uterine wall is adenomyosis and uterine fibroid and cervical stenosis following surgery. And outside the uterus is endometriosis, pelvic inflammatory disease, pelvic adhesions, and pelvic congestions and ovarian tumors. The management options are history, that is pain associated fevers, menorrhagia, dyspareunia, urinary tract abnormalities, and vaginal discharge. The examination is general physical examination, that is pulse, BP, temperature, and weight. And the pelvic examination, which is inspection of the vulva, the imperforate hymen, plus vaginal discharge and polyp, and intrauterine contraceptive device. Then ultrasound is done to diagnose the congenital abnormalities of the uterus, the fibroids or tubo ovarian masses, and the PID. Then laparoscopy is done, which is the investigation of choice where no gross lesions are detected or when nature of the lesions not clear on ultrasound. Then hysteroscopy is done for endometrial polyp and some mucous fibroid, and blood test are done, that is full blood count, especially HB in patients with associated menstrual problems. The treatment options are causative treatment, which is aimed to eradicate the cause, and medical treatment, which is danazol and antibiotic for the treatment of endometriosis and pelvic inflammatory disease. Then conservative surgery, then the radical surgery, then myomectomy. And for congenital abnormalities, surgical correction, cervical dilatation, polypectomy, uterine contraceptive device is removed, progesterone and dihydroergotamine, and psychotherapy is done. For primary amenorrhea, this is primary amenorrhea. So for primary amenorrhea, we are having the medical treatment, which is prostaglandin synthase inhibitors and combined oral contraceptive pills and calcium channel blockers, beta receptor stimulators, and surgical treatment is dilatation and uretage and presacral neurectomy. Okay. So we have discussed the topic, the post-menopausal bleeding. Then we have discussed the secondary dysmenorrhea. Now we will discuss the third topic, that is menopause. So we are having a scenario. Let's change the color. Okay. So we have menopause. The scenario is that there is a 55-year-old postmenopausal lady present with vasomotor and symphysis and body aches. Now, what are the symptoms of menopause and management? Enumerate the contraindications of hormonal therapy. Now the other scenario is that the 55-year-old lady history of cessation of the period since 1 year, suffering from hot flashes and baked aches. So what are the diagnosis, investigation, the management, and differential diagnosis? A differential diagnosis of the menopause are premenstrual syndrome, endogenous depression, hyperthyroidism, and pheochromocytomas. The scenario is that there is this is discussed the HRT hormone replacement therapy and its uses and drawbacks. Okay, so in this section we will discuss the HRT, that is hormone resistance therapy, and also the postmenopausal symptoms of the patient. Okay, so this is menopause. What is the definition? Menopause is end of the reproductive life and is defined as the permanent cessation of the menstruation which occurs at an average of age of 51 years. Or a time comes when raised gonadotropin levels fail to achieve any significant follicular growth and estrogen produce is not sufficient to cause endometrial growth, which results in the cessation of menstruation and woman enters into the menopause. So this is the menopause, that it is the end or cessation of the reproductive life. Now, what are the symptoms of menopause? These are short-term effects and long-term effects. So the short-term effects of the menopause are hot flashes, that is intense heat starting from the face, forehead, neck, chest, or earlobe and spreading to any direction. Night sweats, irritability, lethargy, and insomnia is present. Then we have the genitourinary symptoms, which are urinary symptoms, dysuria, frequency, urgency, and difficulties in incontinence. Then we have the general symptoms, which are dyspareunia, aparunia, genital tract trauma, loss of the libido, and UV prolapse. Then we have the psychological symptoms, which are anxiety, irritability, depression, fluctuations of the mood, inability to concentrate, and poor memory and lethargy. Now, the long-term effects are ischemic heart disease, that is increased risk, osteoporosis, that is decreased mass and increased risk of the fracture. Then the skin, Alzheimer's disease, that is increased risk and infertility. The investigation options are gonadotropin assessment, that is follicle stimulating hormone level is checked, which is greater than 15 IU per ml, and a follicle stimulating hormone level greater than 40. Then we have the baseline investigations, which are CBC, hepatitis B, HIV screening, blood group, and urine RE. Then we will do the specific investigations, which are increased gonadotropin. The treatment options are hormonal and non-hormonal. The non-hormonal treatment are tibolone, that is estrogenic, progestogenic, androgenic properties. 2.5 milligram per day reduces hot flashes and improve libido. Now, calcitonin is given, which is increased bone mass, and biphosphonates are given, which is increase the bone mass, and exercises then decrease the chance of osteoporosis and depression. Then calcium supplements are given along with the estrogens, which decrease osteoporosis, and hypnotic sedatives and tranquilizers are given in used in long-term effects. Okay, so this is the hormonal replacement therapy. So first, let's revise the menopause. Then we will discuss the HRT specifically. So we have a scenario that there is a 54-year-old menopausal lady present with vasomotor and symptoms and body aches. What are symptoms of menopause and the management and the immunity? Another scenario is that this is a 55-year-old lady history of cessation of the period since 1 year, suffering from hot flashes and baked aches. Now the scenario is that we have discussed the menopause, that it is the end of reproductive life and is defined as permanent cessation of the menstruation which occurs at an average age of 51 years. Then the symptoms of the menopause are short-term effects and long-term effects. The short-term effects are hot flashes, that is intense heat starting from face, forehead, neck, chest, or earlobe and spreading to any direction, night sweats, irritability, lethargy, and insomnia. Then we have the genitourinary symptoms, which are urinary symptoms, dysuria, frequency, urgency, void, difficulties in incontinence. Genital symptoms are dyspareunia, aparunia, genital tract trauma, loss of libido, and UV prolapse. The psychological symptoms are anxiety, irritability, depression, fluctuations of the mood, inability to concentrate, and poor memory and lethargy. The long-term effects are ischemic heart disease, that is increased risk, osteoporosis, decreased mass, increased risk of the fracture, and the investigation options are gonadotropin assessment, baseline investigations, specific investigations. And the treatment options are both hormonal and non-hormonal. So the hormonal is HRT, hormonal, and the non-hormonal are tibolone, calcitonin, biphosphonates, exercise, calcium supplements, and hypnotic sedatives and tranquilizers. Now coming towards the hormonal replacement therapy, which is specifically asked in the exams. So what are the indications for the hormonal replacement therapy? These are women distressed with perimenopausal symptoms, women at increased risk of the osteoporosis, and women who want to take it by choice. Now the okay, the types of the hormonal replacement therapy are estrogen, progesterone only, estrogen and progesterone combination, estrogen and androgen. So the estrogen alone are natural estrogen and synthetic estrogen. The progestogen alone are control hot flashes and prevent bone loss. The estrogen and progesterone combinations are reassure resume periods. Estrogen androgens are reduce lethargy and improve libido and increase the bone density. Now the route for the hormonal replacement therapy are both oral and non-oral. The oral are contraindicated. The oral methods and the non-oral methods are the vaginal, the percutaneous gel, the subdermal implants, and the transdermal patches. The contraindications of hormonal resistance therapy are absolute and relative. The absolute are the history of the breast cancer, and the relative are hypertension, diabetes mellitus, endometriosis, fibroids, and the history of the thromboembolism. The pre-treatment evaluation is generally HRT to the woman benefits and risks associated with it. Before prescribing should be discussed in detail, and blood pressure and weight is recorded, and breast should be examined for any lumps, and pelvic examination is performed for any mass, and cervical smear is carried out. Pre-treatment mammography is indicated. Other option investigations are blood sugar estimation, bone densitometry, RFTs, LFTs, lipid profile, pelvic ultrasound, and endometrial sampling. Follow-up study, that is follow-up should be done for assessment of benefits and side effects of the drug. Is first in at 3 months and then annually. Patient is seen first at 3 months and then annually. On follow-up, patient is inquired about symptomatic control, breast tenderness and leg cramps, BP, and weight is recorded. The side effects or risk factors for a hormone-resistant therapy is the return of the menstruation in post-menopausal women, premenstrual syndrome like symptoms, blocking fluid retention, mastalgia, headache and depression, disturbance in the lipid metabolism, thromboembolism, and endometrial cancer, ovarian cancer, and breast cancer are the increased risk factors. Okay, so we have discussed the topic menopause, then we have discussed the definition, the symptoms of menopause, then we have discussed the long-term effects and the short-term effects and the investigation options that are done. Then we have discussed the treatment options, which are both the non-hormonal and the hormonal. The non-hormonal are tibolone, calcitonin, bisphosphonates, exercise, calcium supplements, hypnotics and sedatives, and tranquilizers. In hormonal therapy, we have first discussed its indications. Women distressed with perimenopausal symptoms, women at increased risk of osteoporosis, and women who want to take it by choice. These are the indications. Then we will discuss the types of HRT, which are estrogen alone, progesterone alone, estrogen and progesterone combinations, and estrogen and androgens. Then we have both we can administer the HRT both orally and non-orally. The non-oral routes are vaginal and vaginal creams, percutaneous gel, subdermal implants, and transdermal patches. Then we have discussed the pre-treatment evaluation of the patient for HRT. Then what are the other optional investigations, and then we have discussed the follow-up of the patient who are given the HRT, and then we have discussed the side effects or risk factors of the HRT. So we have discussed the 3 topics, that is the postmenopausal bleeding, and the secondary dysmenorrhea, and the menopause. Okay. And these postmenopausal bleeding, secondary dysmenorrhea, and menopause. In the next section, we will discuss the abortion, the recurrent abortion, the septic abortion, the incomplete abortion, and the threaded abortion. We will try to complete all the abortion part in just one section of the video. Thanks for watching.